Good evening, everybody. Welcome to Queensland X-Ray's webinar on nuclear medicine imaging with applications within primary care. This is my first webinar and Queensland X-Ray's second only webinar, so please forgive us if there's a few minor glitches on the way. So just briefly, a little bit about myself. So I graduated from UQ in 1986 and trained originally in the Royal Brisbane Hospital. And initially I was there just paediatrician training at the Royal Children's Hospital and then I became a consultant paediatrician in 1996 and spent 10 years in general pediatrics and neonatology. And then in around 2006, I switched over to nuclear medicine, training at the Royal Brisbane PA. And initially I was a VMO in PA Hospital and at IMED Radiology, the Wesley. And then I joined Queensland X-Ray about 18 months ago to help with the PET and nuclear medicine. So, tonight, this is just a brief outline we're going to cover. So first of all, I'll just do some basics about nuclear medicine and how images are acquired. And then I'm going to talk about some specific applications in primary healthcare. I'm going to focus a lot on myocardial perfusion imaging because that's probably one of the most underutilized nuclear medicine modalities within general practice, and is eminently accessible from the primary care point of view. I'm going to briefly mention bone scans with a specific interest in back pain. A brief mention of thyroid scans, VQ lung scans, cerebral perfusion studies, and if we've got time, a little bit about a little known nuclear medicine modality called reflux scintigraphy. And then John Barlow, the operations manager for Queensland X-Ray PET and nuclear medicine, will be discussing some of the Medicare and cost implications. And then we're going to have a little time for questions and answers. So firstly, what is nuclear medicine? Now, nuclear medicine is an emissions technology rather than transmission, which is traditional CT. So in nuclear medicine, the patient is the X-ray source. We utilize predominantly technetium-based radio tracers in general nuclear medicine, and obviously we use PET tracers for PET. The technetium has a 6-hour half-life and is usually given intravenously. So we did METS gamma photons with an energy of 160 keV. And the technetium is bound to specific ligand molecules. And the organs that it targets depend on the ligand's pharmacokinetics. So this is a hybrid gamma camera. All our gamma cameras are now hybrids. So they've got a gamma camera detectors at the front with a CT scan, which is 2 to 16 slice. So during the uptake phase, the tracer with the ligand localizes to the target tissue predominantly. And the patient's presented the gamma camera, the technetium emits gamma rays. The gamma rays interact with sodium iodine crystals in the gamma camera detectors, which produces scintillation. The scintillation is converted to an electronic signal and a map's produced by filtering and computer processing. Now we usually do planar sweep and/or SPECT. So SPECT is single photon emission computed tomography, and the images are produced. And as I mentioned, all our cameras have low-dose CT, which is acquired at the target region. That could be a big example, heart or the torso. And the CT is fused with the SPECT images to produce the pretty pictures. So this is insides of a basic gamma camera. Now this bottom part is the sodium iodine crystals, and these are what we call the photomultiplier tubes. So the gamma ray enters, the gamma photon enters the scintillation crystals, produces low energy photons, which are detected by the photocathode, and then they're amplified by the photomultiplier tubes to an electronic signal, which is processed by the computer. So this is just the planar sweep acquisition with the detectors there. And then this will be the position of the cameras for the SPECT as it rotates around the patient's target organs. And this is just the basics of how the SPECT, so the SPECT is based on filtered back projection with the detectors moving around the patient, and gradually a point source is produced. So now we'll just move on to some clinical applications in primary care. So as I mentioned, these are a few things I'm going to talk about. So we're going to talk about the investigation of chest pain and shortness of breath, specifically myocardial fusion scans and then VQ scans. We'll talk about the investigation of back pain, a little bit about diagnosis of stress fractures, scleral metastases, osteomyelitis, thyroid disease, in particular hypothyroidism, cerebral fusion studies with reference to dementia, and then reflux scintigraphy. So myocardial fusion scans. So just quickly, the general clinical indication for MPS. Now, MPS is reserved usually for patients with low to intermediate cardiovascular risk factors. Patients with very high cardiovascular risk factors and typical chest pain should obviously have angiography by cardiology. Now, the patients have to have symptoms, which of course is chest pain, which can be atypical or typical. Has to be preferably troponin negative. If the patient's troponin positive, then once again they should see cardiologist for angiography, and/or they can have dyspnea, which is the angina equivalent. Now, from a Medicare point of view, they have to have symptoms plus they have to have inability to perform stress echocardiography. This rule was introduced about 3 years ago. So an inability to perform a stress echocardiography basically means they can't perform high-level treadmill exercise, or they're likely to have poor acoustic windows, for example, high BMI greater than 30. As well, sometimes the baseline ECG abnormality makes it difficult to undergo a stress echo. For example, left bundle, that obviously limits exercise, and frequent ectopics can limit the utility of stress echocardiography. Another subgroup that we can do MPS is on a Medicare point of view are patients with known coronary disease and they require assessment of perfusion post-CABG, or if they've got a stent stenosis on angiography or CTCA, and you want to determine if it's functionally significant. So a little bit about the sensitivity of MPS compared to other modalities. So it actually has quite high sensitivity of 85% and a specificity of 85%. For the detection of severe stenotic disease, that's greater than 70%. So that's similar to stress echocardiography. It's higher than exercise test alone, EST alone, which has a sensitivity of a specificity of around 65%. Now, EST alone has especially poor specificity in middle-aged women who have a high false positive rate of ST depression. Now, in very large historical multi-center trials, a normal MPS was proven to have less than 1% risk of adverse cardiac events in the next 2 years. So basically, a normal MPS gives the patient a 2-year warranty. Now, how does it compare to stress echocardiography? So it's similar clinical indications, similar specificity and sensitivity. However, echo is highly operator dependent, whereas nuclear medicine MPS is not. Echo can be technically difficult in patients who are obese with COPD and regional wall motion abnormalities, for example, left bundle branch block or previous infarct. Many patients cannot exercise to adequate cardiac workload for an exercise stress echo. And if you end up using dobutamine pharmacological stress echo, dobutamine has a higher incidence of side effects, for example, palpitations, arrhythmias, than vasodilators such as adenosine. And also, dobutamine induces true myocardial ischemia, whereas adenosine does not. We'll talk about that shortly. So how does MPS basically work? So first of all, we use a cardiac tracer, and that's almost always sestamibi and Queensland X-ray. And the sestamibi has a very high fast uptake by myocardial cells, where it's bound to mitochondria until it decays. So the regional uptake we see in the images is proportional to perfusion at the time of injection. So it takes a snapshot of perfusion at that moment in time. So the tracer is first injected at rest and scanned 30 minutes later. And then the same tracer is re-injected at a higher dose, 3 times the dose usually, at peak stress. And presently that's usually pharmacological due to the change in Medicare rules. So post-stress scanning is usually done within 1 hour of stress dose. So the patient doesn't have to scanning straight after peak stress. They can sit around and wait for the time on the camera. Now, just a bit about the radiation dosimetry, because that often comes up when talking about nuclear medicine compared to other modalities. So the average total dose for MPS is 8 millisieverts, including the one millisieverts for the low dose CT chest. So in comparison, the annual background radiation dose for Australians is 2 millisieverts. The chest X-ray is 0.2 millisieverts, but an abdominal CT, which people never think twice about, is around 10, and the stress echo is obviously 0. So I'm just going to talk a little bit about adenosine because that's the only stress agent we use at the moment because diprodamol is no longer available, and adenosine is actually quicker and more effective, I think. So adenosine induces direct coronary arterial vasodilatation by the A2A receptor. It produces a 3 to 4-fold increase in myocardial blood flow. Now, normal vessels, when they're dilated, steal or divert blood from stenosed vessels, which usually greater than 70%, and that is the reduced coronary flow reserve we talk about in the report. So adenosine doesn't usually induce true myocardial ischemia, except rarely in patients with critical stenosis, because it's just producing different regional uptake at the time of stress. This is just a little slide just talking about the different receptors. So unfortunately, adenosine does not only stimulate the vasodilator receptors, it also affects bronchi and also the atrial conduction. We'll talk about that later. So side effects. Now, most patients experience mild transient side effects, and that's due to the non-selective activation of the other receptors. So the most common side effects is a bit of flushing. A lot of patients get mild central discomfort. Some patients get dyspnea and chest tightness, including bronchospasm. And dizziness and nausea is not uncommon. Some patients become slightly hypertensive, and there's certainly a transient second-degree heart block that can occur. But if any side effects occur, the beauty of adenosine is it has a very short half-life, less than 10 seconds. So there's rapid resolution of side effects once the infusion stops, and rarely requires reversible intravenous aminophylline. I was personally involved in over 10,000 adenosine stress tests, and I had to use aminophylline twice to reverse severe bronchospasm. So it is very safe. It's at least less than 1 in 10,000 serious adverse events in large groups of patients. So who can't have adenosine? Well, patients who are bigger than the scanner. Severe claustrophobia can obviously limiting because the heads of the camera come fairly close to the patient's face. We don't do it in pregnancy for obvious reasons. One beauty of adenosine stress testing is not renal function sensitive like intravenous iodine contrast. An allergy to the sestamine tracer is extremely rare. Now, some very specific contraindications. If a patient has brittle asthma, for example, steroid-dependent, recent ICU admission, then they should not have adenosine because they can have severe bronchospasm. I don't give it to patients with severe COPD, especially if they're home oxygen dependent, because those patients may have a little bit of reversible airways disease, and if you take that away from them, they become very distressed. But in these sort of groups, in these two groups, we can actually use intravenous dobutamine at our sites as a stress agent, and it's done exactly the same as per stress echocardiography. Under patients with stable asthma can have intravenous adenosine. What I usually do with them is we give them pre-treat them with nebulized salbutamol, or we actually give them a half dose for a minute and then we'll bump up to the full dose. Patients with second or third degree heart block should not have adenosine because it usually produces a first degree heart block. And if you give these patients adenosine, they may have a complete heart block, which is difficult to recover from. Hypertension, bradycardia. If the patient's had diprodamol in the previous 2 days, we avoid adenosine because this drug can actually accentuate the effects of it. The one unfortunate side effect is caffeine can block adenosine. So patients have to have no coffee or caffeine containing foods for at least 12 hours prior. I have seen patients have quite severe caffeine withdrawal because of this. If they've had an infarct in the preceding 48 hours, then they shouldn't have any form of stress testing. And rarely, I've never seen a patient have hypersensitivity. Well, if they've had a history of adverse event, then adenosine, they obviously shouldn't have it. Just briefly about the patient information. So it takes 2 to 3 hours. They can drive afterwards, and there's minimal really patient preparations. Fast 4 hours, caffeine, no, not for 12 hours. We tend to give them all the usual meds except for oligoprotein theophylline. Theophylline blocks adenosine, and if patients not theophylline, it means they've got bad airways disease, so they shouldn't have it. We don't usually stop the beta blockers because that can actually cause some issues with the arrhythmias. And just to mention, all our Queensland X-ray sites across the state have weekly MPS lists. Toowoomba has lists 4 days a week. So how do we as nuclear medicine physicians and radiologists interpret the MPS images? So it's basically just a comparison of rest and stress tracer distribution. A reduced stress versus rest uptake in a myocardial segment equals a reversible perfusion defects, and it's indicative of greater than 7% coronary stenosis, which is functionally significant. Now, if the patient has a fixed perfusion defect, it may represent inactive myocardium secondary to an infarct. It's not uncommon to get soft tissue attenuation artifacts, and that's part of our skill in reading those. Males particularly have inferior segment defects due to subdiaphragmatic attenuation. Females not infrequently have anteroapical segment breast attenuation defects due to breast opposite. We use the low-dose CT of the chest as an attenuation correction map, and that's quite helpful in males. So just a few clinical little examples. So these are some of the pictures that are produced. This is the SAVE screen of the left ventricular myocardium at different planes. So this is what we call a short axis plane. That's the anterior wall, the lateral wall, septum, and the inferior segment. And this is the vertical long axis, so the anterior, apical, inferior. And this is the horizontal axis, which is septum, lateral wall, and apex. So this is a nice normal study in that everything looks matched. There's no real difference between the rest and the stress images. Stress are traditionally on top, rest images on the bottom. This is a female patient. She's got a mild breast attenuation artifact, so a small match defect in the apex. And this is just some of the computer software can divide it up into 3 vessel coronary territories, LAD, circumflex, and RCA. And then there's also a 17 segment program, which looks at base, mid, distal of each of the different segments, regions I talked about. And then we have these things called some stress scores, some rest scores, and some different scores. I'll go into that shortly. And this is just an example of how the different segments can be divided up anatomically. Sorry, I go the wrong way. Oops. So sorry, this is the normal study again, and this is just introduces that what we call polar map software. Didn't come out very well, but these actually have scores of 0. So we score them from 0 to 4. So 0 is normal, 1 is mild perfusion, mild severity perfusion defect, 2 is moderate, 3 is severe, and 4 is completely absent, which usually means an infarct. And then I'll just have some examples of some abnormal ones. So this patient, so this is the stress and this is the rest. In the rest, you can see it's a nice, fairly smooth, homogeneous tracer uptake, which represents perfusion. And following stress, the patient has a moderate reduction in perfusion of the anteroseptal, anterior, and also the apical segments. So this patient likely has significant LAD stenosis. And in this sort of patient, we would make some recommendations. And one of them would be that they attend for semi-urgent cardiology referral. So because they'll likely require formal coronary angiography. And this is the same patient, and this is the patient's polar maps. So you can see in the stress score, they've got areas of quite severe reduction in perfusion scored 3, and the rest score there's a minor reduction. And this is probably the most important polar map of all, because this is the sum difference score. So it takes away the rest score from the stress score, and if that's abnormal, that may indicate reversible perfusion defect. So this is a slightly different scenario. This patient does have a defect in their rest images of moderate severity, but when the patient had adenosine, the defect got a lot larger. So this is an example of a patient with a fixed defect of rest, which represents an infarct, and that's in the infralateral territory. And it becomes larger in the stress images. So this patient has some peri-infarct reversibility. And this is a left circumflex territory segment. So this patient should also have formal coronary angiography. And this one is the same patient with the polar maps. So you can see that in the rest, they have a significant defect there, and the stress, it gets a lot larger. And these little tables here are quite useful to look at, because it actually tells you which segment, which territory it's in, and what the extent of the defect is. It involves the entire infralateral segment after stress. Now, this is just an example of the same patient. This is polar mass with the vessel territory. So you can see that it involves the left circumflex territory predominantly. Now, one other thing we can do with the cardiacs is we can actually get a very good assessment of the LV function. And the way that the computer does that is that we have a patient's monitored the whole time, and it breaks up the systole and diastole into 8 different segments and bins the information in each of those segments. And that's called ECG gating. And so it produces, and we put regions around the myocardium, and then it produces, it gives us an idea of the wall motion. This patient says, and then it produces a polar map of the wall motion as well. So this patient's wall motion is completely normal. And we get an estimate of the LV, the actual ejection fraction, which is actually compares quite favorably to echocardiography assessment of LV function. Now, apart from the low-dose CT producing attenuation correction maps that help us eliminate attenuation artifact, it also provides quite useful information for in other regions. For example, we can assess coronary calcification, and that's supportive of the diagnosis of coronary disease, obviously. There's not a proper coronary calcium score, but it helps with our interpretation of the images. And the other thing that we not infrequently see is incidental findings, for example, pulmonary nodules. The CT does not include the entire chest, though. It's for the cardiac region. So just about adenosine MPS in summary. So it's sensitive to the diagnosis of flow-limiting coronary disease. Minimal patient preparation is required. There's few absolute contraindications, such as brittle asthma. It has a very good safety profile, and as John Barlow is going to talk about shortly, it's accessible and bulk billable from the primary practice point of view. So I'm just going to touch on bone scans quickly. So bone scans use a different tracer, technetium Batesville, HDP. So that's its uptake. It is uptake proportion of the osteoplastic bone or new bone, osteoplastic or new bone turnover. And once again, we do SPECT images with fusion to low-dose CT. That allows accurate anatomical localization of the uptake, as well as some correlation with bone pathology. Now, dosimetry is less than MPS. It's 5, whereas MPS is about 8. Now, one of the most useful applications of bone scans in general practice is in the investigation of back pain. And the reason for that is it allows targeting of facet joints for HCLA or RFA therapy. Bone scans are actually more specific than CT or MRI in identifying active or hot facet joints, which are more likely to respond to therapy. There's been large randomized controlled trials which have demonstrated this. One in particular, in a consensus paper, demonstrated that 80% of patients reported improved pain at 1 month versus 31% of patients with no bone scan. And a result in reduced number of facets injected with overall cost saving. Once again, all patients have low density SPECT for the accurate location, and also it allows grading, which I'll talk about shortly. The fused CT allows potential diagnosis of other causes of back pain, like for example, active sacroiliitis, which is often missed, vertebral body fractures, sacral insufficiency fractures, which are also often missed in elderly patients, skeletal metastatic disease, and also infective discitis. The other thing about bone scans and back pain, it actually applied to cervical and thoracic spines, but it's not quite as well studied. And you can actually also use in mid-feet for targeted injections. So this is just an example of fused CT specs. So this patient has moderate uptake in their L3-4 and mild uptake in their right L5-S1. But you note that the severity on CT looks fairly similar. In fact, the mild one looks more severe on CT than the L3-4. But the intensity uptake is higher in the L3-4. So this is the facet joint that should probably be targeted. I mean, obviously, you have to have some clinical correlation as well. Another useful thing for bone scans is the diagnosis of rib fractures. Rib fractures are often missed on chest X-ray, and also if they're not displaced, they can be missed on diagnostic CT, but they are almost, bone scans highly sensitive and they always light up. As I mentioned, sacral insufficiency fractures are commonly missed. This patient has the typical H-type uptake, and then they've got the sclerosis within the sacrum on low-dose CT. Another useful thing about bone scans investigating low back pain is incidental findings. This patient presented with low back pain radiating to the left leg, and she had an undiagnosed fractured neck of femur. Right. Now, bone scans are very useful for investigation of stress fractures. If the bone scan is negative, then the patient does not have a stress fracture. And now we fuse it with CT, so we get a very accurate localization. This patient has an navicular stress fracture. The other useful area for stress fractures for bone scans are tibial stress fractures or shin splints. This patient has the typical diffuse linear uptake in the posterior medial aspects of both tibias. Right, so bone scans in oncology. I mean, PET imaging has taken over a lot of this work for all common cancers. John Bartlett's going to talk briefly about this. But it's still quite commonly used to monitor many cancers, especially prostate and breast after treatment. And it's quite useful if the patient develops new symptoms, and then we can check for any presence of skeletal metastatic disease. Osteomyelitis, it's still quite a useful test in the investigation of that, especially in the feet. A negative triple bone scan completely excludes osteomyelitis. And the fusion with CT SPECT images has helped us improve our sensitivity and specificity. So thyroid scans. We use protector tape. It can be blocked by thyroxine, so it's no use in the investigation of hypothyroidism. It's very useful in diagnosing underlying cause of hypothyroidism. So these are the main causes of hypothyroidism we see on protector tape scans. So it's Graves' disease. This patient has diffuse homogeneous increased uptake. This patient has a toxic multinodular goiter with multiple autonomous hyperfunctioning nodules. This patient has one large autonomous hyperfunctioning nodule with suppression of activity in the remainder of the thyroid gland. And this patient has no uptake in the thyroid bed, and that's often due to an acute thyroiditis, usually Hashimoto's. Excuse the spelling error. So BQ scans. So BQ scans are obviously originally the only way to diagnose pulmonary embolism. A lot of that's been taken over by CTPA, but there's a few specific cases where BQ scan is quite useful. One of them would be pregnancy, because the CTPA gives a high dose to breast tissue, and there's a risk of contrast allergy, which is increased in pregnant women. So in pregnancy, we give them a perfusion-only scan half dose. We don't give them a low dose CT, like we did for any other patient. Now, the baby has a quite low field exposure, less than 1 millisievert. The maximum allowed exposure for a fetus is 1 millisievert. So that is slightly higher than the CTPA, but it's still quite low. And we do SPECT on all patients, and that has improved the sensitivity to about 83% and the specificity to 95%. So that's actually similar to CTPA. So this is a normal SPECT of perfusion SPECT, and this patient has, so that's vent and that's perfusion. This patient has large segmental and subsegmental perfusion defects, which are not matched in the vent, so that's pulmonary embolism. I'm running out of time, but I'm just going to mention dementia scans. So cerebral perfusion scan is another underutilized scan, I think, in general practice. So it uses perfusion agents, HMPA or ECD. They rapidly cross the blood-brain barrier. They're small size, and so they've got a high degree of brain extraction, and they distribute according to cerebral blood flow. So similar to what sestimivir does in the heart. Now we use quantitative analysis software, so it compares to age-appropriate normal database, and standard deviation greater than -2 is significant. And now the hyperfusions are secondary to reduced metabolism in areas of neuronal depletion. The sensitivity and specificity, for example, for AD is quite high, 80 to 90%, and it often predates the anatomical MRI or CT changes. So Alzheimer's classically produces bilateral, posterior temporal, parietal, and precuneus hyperfusion. FTD produces anterior frontal and temporal hyperfusion, and vascular can produce multiple asymmetrical defects. But these two processes, vascular and neurodegenerative diseases, can often occur in the same patient. So just an example of fused CT spectrum, which is with the perfusion agent. This patient has nice normal uptake. And then this is an example of our surface projection we are able to acquire. So if any of these areas light up, then that means the standard deviation is greater than -2, but this one's essentially normal. It's rare to get a completely pristine surface projection. Whereas this patient has probable Alzheimer's disease. They have temporal and parietal hyperperfusion and a bit of frontal and sparing of sensorimotor. And they've got what we call precuneus involvement as well. And this patient probably has frontotemporal dementia with predominantly anterior hyperperfusion of the frontal and temporal lobes, with sparing of the parietal lobes and the occipital lobes. I'll just very briefly mention reflux scintigraphy. So this is a way of diagnosing reflux. We give them a small dose of DTPA orally. We do some supine acquisition for 90 seconds. Then we do some delayed statics, and we then roll them around. It's actually fairly sensitive for the diagnosis of high-grade reflux, 60 to 80%, and also allows assessment of esophageal transit. We do some delayed images, and that sometimes picks up the presence of lung aspiration. This is a normal study with rapid passage of the radiolabeled bolus into the stomach. And then we do time activity curves for regions, the upper, mid, and lower. And this is a nice rise and then complete falls back to baselines. And this is an example of the esophageal transit measurements we get. Normal is less than 15 seconds. This is the delayed post-maneuver images. So this patient has no residual esophageal activity and no obvious lung contamination or airway contamination. And this is an example of a positive study. So there's initial normal movement, and then subsequently there's a peak in the time activity curves with frequent reflux. Okay, that's my finished.